No.
Yeah, you can, yes, you can leave it that way, and then
Okay.
I'll hand it over to you, and then we can start officially. Yeah.
Okay.
All right. All right. Good evening, everyone. Thank you very much for joining us for our clinical nephrology subcommittee talk for today. We will have with us today Prof. Yazid Chotia. He will be taking us through electrolyte and acid-base disorders, a case-based approach. But before I hand over the mic to him, I would like to just briefly introduce him. To start off with, Prof is my mentor. I trained under him at Tigerberg Hospital, but he is also a nephrologist at Stellenbosch University and Tigerberg Hospital in Cape Town, South Africa. He has an extensive experience with clinical training of undergraduate and postgraduate medical students and has supervised many postgraduate research projects, MEd and MPhil degrees. I've had the pleasure of publishing a couple of papers myself with him. Nationally, he is an examiner for the fellowship of the College of Physicians and an examiner and a convener for the Certificate of Nephrology. Prof. Chothia's passion for teaching was recognized when he received an award from Stellenbosch University for the bedside teaching of undergraduate students. Prof. Chothia is an active researcher and has published in local and international journals. One of his publications, a report on the randomized trial of novel treatment for hyperkalemia, has garnered many citations, which led to his PhD on the, the emerging, improving the emergency management of hyperkalemia. He has presented his work at national and international meetings, including the ASN's Kidney Week, the World Congress of Nephrology, and the Congress of African Association of Nephrology. Nationally, he is an executive committee member of the South African Nephrology Society, and internationally, a member of the African Association of Nephrology Research and Ethics Committee. Prof. Chothia has recently been certified as a mentor by the International Society of Nephrology and is an associate editor with African Journal of Nephrology and PLOS ONE. Regarding his community interactions, he is involved in raising funds for patients with kidney failure to broaden access to kidney replacement therapy, and recently teamed up with the Gift of the Givers to support patients with bridging dialysis. He is a regular guest speaker for community radio stations and is involved in health education and promotion at the local running club. So, with that, Prof, I hand over the mic to you. You're most welcome. Thank you.
Thank you, Mazar, for that kind introduction. And thank you for the invitation to present at this webinar. So I was my topic is going to be on electrolyte and acid-base disorders, and I'm going to use cases to teach our approach at Tygerberg Hospital and Stellenbosch University to these disorders. So I've no disclosures, and I'm going to present two cases. The first is going to be a case of hyperkalemia and lethargy, and the second will be hypokalemia and metabolic acid alkalosis in the ICU. So the first case is a 53-year-old man who presented with complaints of lethargy for 6 months. And on clinical examination, he had a contracted ECF volume, and nothing else abnormal was identified on clinical examination. So these are his blood tests, both plasma and urine results. And one can see here that the patient had a high potassium, borderline high, 5,5, and he also had some renal kidney dysfunction. And the blood gas indicated a mild metabolic acidosis. So what is the interpretation of these results? We can say that he's got hyperkalemia. And the first question one should always ask yourself is actually, is the patient at risk for arrhythmias or muscle weakness? In this case, that was not the case. And we wanted to know, was the patient's kidneys responding appropriately to this hyperkalemia? Now, during hyperkalemia, the kidneys has a capacity to excrete more than 200 millimoles of potassium per day in the urine. And the ratio of potassium to creatinine in the urine in the face of hyperkalemia should be more than 20, indicating an appropriate renal response. As we can see, in our case, the potassium to creatinine ratio in the urine was 3,7. So it was substantially less than 20, and this indicated an inappropriate renal response in the face of hyperkalemia, meaning the cause of the hyperkalemia was related to a kidney problem. Second, we were told in the history that the patient had ECF volume contraction. And what one should always ask, what is an appropriate renal response to volume contraction? When the patient is hypovolemic, what should the kidneys be doing? And what we can find here is that the urine sodium concentration was very high. It was 121 millimoles per liter. So when one is hypovolemic or ECF volume contraction, an appropriate renal response is really to conserve as much sodium as possible. And the number to remember is a sodium concentration of less than 20 millimoles per liter. So again, we can see that there is substantial sodium wasting, or what we would then refer to as renal salt wasting. And then with regards to the acid-base abnormality, the patient had a low pH with a low bicarbonate concentration. And we can then say that the patient does have a metabolic acidosis. The next step in any patient with metabolic acidosis is to decide, is it a high anion gap or a normal anion gap metabolic acidosis? What we found was that the patient's anion gap was 17.5 millimoles per liter, and this indicated a normal anion gap metabolic acidosis. And I will get to all of these findings in more detail. I'll describe all of these findings in more detail as we move along. Now, I just want to make the point at this now that when one is confronted with any acid base or electrolyte abnormality, you should choose one abnormality and dissect the cause of that abnormality until the very end. And it doesn't matter where you start. In this case, whether we start with the hyperkalemia or whether we start with the ECF volume contraction and salt wasting, or whether we start with the metabolic acidosis, we will end up with the same conclusion in terms of diagnosis. And I'll demonstrate that now as we move on. So when it comes to potassium, you need to understand how the kidneys normally handle potassium. And the fine tuning of potassium excretion occurs in this part of the nephron called the cortical collecting duct. So this is a bit of an animation. So just watch what happens. As sodium is delivered and chloride, sodium enters the principal cell through the ENaC channel or the epithelial sodium channel, and chloride moves paracellularly between cells. I'll just show that again. So sodium moves through ENaC while chloride moves paracellularly. Now, when the sodium concentration increases inside cells, as has occurred here, it activates the excretion or secretion of potassium through a channel here, the green channel, which is called ROMK. And the potassium then comes out. The other important thing just to remember, potassium doesn't get secreted really, it gets pulled out through ROMK because of this lumen negative charge. The lumen negative charge occurs because sodium absorption occurs more rapidly relative to chloride absorption. So let's say for every 100 sodiums that gets absorbed here, only 90 chlorides gets absorbed through the paracellular pathway. That means there are 10 chlorides remaining in the lumen, which increases the lumen negative charge inside the cortical collecting duct. And that lumen negative charge drags 10 millimoles of potassium from the principal cells. And that is eventually how we excrete potassium in the urine. along with its negative anion. Now, when a patient develops hyperkalemia, it's really because the lumen negative charge in the cortical collecting duct is less negative. In other words, the less negative the charge inside the lumen, the less potassiums that are secreted and excreted in the urine. So when one is confronted with a renal cause for hyperkalemia, you must identify why the lumen negative charge in the cortical collecting duct is less negative than one would like. So just to demonstrate this, there are really two mechanisms for how this occurs. The first is either sodium is absorbed more slowly or chloride is absorbed more quickly for the lumen negative charge to move towards a more positive charge. Now, in these two scenarios, with regards to the slower sodium reabsorption, the detail here is not important, but what I'd like you to take note of is that it's all related to aldosterone activity or the aldosterone receptor that's not working properly or being blocked, or the ENaC channel activity that is reduced, which is a result of the aldosterone inserting more ENaC channels. So it's all related to aldosterone and a deficiency of aldosterone when the cause is slower sodium reabsorption. In the case of faster chloride reabsorption, these are really rare causes of hyperkalemia. The one is when the activity of the sodium chloride co-transporter activity is reduced in the distal convoluted tubule. This is also referred to as the thiazide sensitive channel. And there is a rare condition called Gordon syndrome, which increases the activity of this sodium chloride co-transporter channel, quite a rare condition. The other is a chloride shunt. So something shunts the chloride absorption, which also reduces or increases the lumen charge in the cortical collecting duct. An example of this would be cyclosporin use. In fact, the mechanism by which cyclosporin causes hyperkalemia is through shunting of chloride in the cortical collecting duct of the nephron. Now, there is a way to distinguish these two mechanisms based on the blood pressure. When there is a deficiency of aldosterone or the effect of aldosterone or the ENaC channel, the patients will either be normotensive or hypotensive, like I'm indicating here. Or in the case of faster chloride shunting or increased activity of the sodium chloride co-transporter channel, the patients will be hypertensive. So in our patient, the patient was actually ECF volume contracted, as I mentioned in the history. So our patient seems to be in this section of this diagram. In other words, there seems to be slower sodium reabsorption and something affecting the activity of aldosterone, or aldosterone effect is being blocked. Now, just a little bit more on body fluid compartments. As total body water consists of, it's 50% in a female and 60% in a male. And whether you're male or female, that total body water is divided up into 2/3 intracellular fluid compartment and 1/3 in the extracellular fluid compartment. And the reason there are more, the reason for the bigger ICF compartment compared to the ECF compartment is because the number of osmoles inside the intracellular fluid compartment is twice that of the ECF compartment. So although there are more osmoles, the volume is also twice as much, and therefore the osmolality between the ICF and the ECF, as you can see here, is exactly the same. So the important concept that one needs to understand here is that sodium content determines the size of the ECF compartment. I want to say that again. Sodium content determines the size of the ECF compartment or the ECF volume. So let's use this hypothetical 1 liter of fluid here, which has 10 sodiums inside of them, 10 sodium molecules. The content of sodium here is 10, but the concentration of sodium is 10 per liter. Now I add another liter. So we now have 2 liters. The content of sodium is now 20 sodiums for 2 liters, but the concentration is still 10 sodiums per liter. In other words, you can see here visually that this compartment here has doubled in size because the content of sodium has increased, yet the concentration has remained unchanged. So sodium content determines the size of the ECF compartment. So what is the kidney's response to ECF volume contraction? Well, let's say we've got 100% of sodium is filtered at the level of the glomerulus. In the face of ECF volume contraction, most of the sodium is reabsorbed along the tubules of the nephron. Here, I've just indicated it by the proximal tubule, although it's not 99% at the proximal tubule. But 99% of sodium is reabsorbed along the course of the nephron in the face of ECF volume contraction. And this results in a fractional excretion of less than 1%. And the reason the kidneys are doing this is it's trying to reabsorb as much sodium molecules as possible in order to increase the sodium content in the body and therefore the ECF volume. So we mentioned that from an ECF volume perspective, the patient did have renal salt wasting. As I mentioned earlier, the kidneys in the face of hypovolemia should be excreting less than 20 millimoles per liter of sodium in the urine. And in our patient here, in this case, it was 121 millimoles while the patient was ECF volume contracted. So the combination of a low effective arterial blood volume along with a high sodium concentration indicates renal salt wasting. And the causes for renal salt wasting is either primary hypoaldosteronism, molecular defects in the aldosterone receptor, ENaC channel abnormalities, etc. Again, we end up from an ECF volume contraction perspective and salt wasting perspective, we end up with the same differential diagnosis as for when from the other ENaC and the faster sodium and chloride reabsorption. So are the kidneys responding appropriately regarding the metabolic acidosis in this case? So just to understand a little bit regarding the way in which the kidneys maintains acid-base balance, first we need to understand that the kidneys doesn't excrete acid or hydrogen ions in the form of hydrogen. And it's simply for the following reason. We can see on the y-axis here that the hydrogen ion concentration in nanomoles per liter, and on the x-axis here, the urine pH. And on this end of the x-axis, the lowest urine pH that the kidneys can produce is around 4. And at this lowest pH, the amount of hydrogen ions in the urine is 10 to the power of 5 nanomoles per liter, or 100,000 nanomoles per liter, which is the equivalent of 0.1 millimoles per liter of hydrogen in the urine when the pH is 4. Now, on a normal Western diet, we consume up to 80 millimoles of hydrogen a day. So if we were to excrete hydrogen or acid in the form of hydrogen only in the urine, and we consumed 80 millimoles of hydrogen a day, we would have to produce 800 liters of urine a day in order to get rid of our hydrogen load that we consume every day. So that is just not going to be realistic. So how does the kidneys maintain acid-base balance? Firstly, Firstly, you need to know there are three things. Firstly, filtered bicarbonate is reabsorbed by the proximal tubule. Here, we don't gain any new bicarbonate. Here, we are simply reabsorbing what we already have. Second, hydrogen secretion in the distal convolute, in the collecting duct here, hydrogen secretion is linked to new bicarbonate generation. And thirdly, we excrete hydrogen in the urine in the form of ammonium. So these are really the three key mechanisms by which the kidneys maintain acid-base balance. And any abnormality of either of these mechanisms will result in a problem, may result in a problem with acid base. So in our patient had a so-called normal anion gap metabolic acidosis. Now, importantly, we must understand that all urine fluid, all body fluid compartments, whether it be serum, urine, CSF, they are all electroneutrally charged. In other words, they are not more negative or positive, they are neutrally charged. If if our urine was negative or positively charged, it would be a shocking experience when going to the toilet to take a wee. So all body fluids are electroneutrally charged. And when we are looking at the urine charge here, we are interested in how much ammonium is being excreted in the urine. In other words, are the kidneys pumping out lots of ammonium in the urine in the face of metabolic acidosis? Just to let you know, the kidney can increase ammonium excretion in the face of metabolic acidosis 100-fold. So there should be, in the face of metabolic acidosis, more than 200 millimoles per day of ammonium in the urine if the kidneys are responding appropriately. So when we're looking at ammonium excretion, we're really interested only in the charged particles in the urine. So you can see in our urine sample here, we also have urea, which is a non-charged organic particle. And we have the total urine osmolality here of 600. So we should remove we should subtract 600 from the 275, which is a non-charged particle. In this case, it's urea. Sometimes there may be glycosuria, and you need to subtract that concentration as well from this osmolality. In this case, there wasn't any glycosuria. So 600 minus 275, the remaining osmoles was 325 osmoles, which were charged particles, either positively charged particles or negatively charged particles. So, and because we know they have to be electroneutral, there should be equal quantities of positive charges as there are negative charges. So in this case, it is 325 divided by 2, which gives me 163 positive charges and 163 negative charges. So we simply now have to put in our concentrations of cations, which in this case here, we've got sodium, which was 121 millimoles, potassium, a chloride, which was 119 millimoles, and potassium, which was 37 millimoles per liter, meaning the amount of ammonium in the urine was only 4.5 millimoles per liter. Just on this, the only cations we excrete in significant quantities in the urine is sodium, potassium, and ammonium. There are very little minute amounts of calcium and magnesium, but the concentrations are so small it doesn't really contribute much to this 163 millimoles here. So, as I mentioned earlier, an appropriate renal response in the face of a metabolic acidosis is to excrete large quantities of ammonium in the urine in excess of 150 to 200 millimoles per day. And in this case, there was only 4.5 millimoles, indicating an inappropriate renal response. So the minute you find that there is very little ammonium in the urine, the diagnosis is renal tubular acidosis, or RTA. And I'd like you to remember it in this way. Remember the ammonium to diagnose renal tubular acidosis, or RTA. So at this point, we can say that this patient has an RTA, or renal tubular acidosis, as a cause of the normal and iron gap metabolic acidosis. So with regards to renal ammonia genesis and excretion, I just want to show you what normally happens, how this is synthesized and produced. So glutamine in the proximal tubule, under the effect of glutaminase, an enzyme found in that part of the tubule of the proximal cells, converts glutamine into ammonium. And the ammonium then is secreted and moves along the nephron and crosses the sodium potassium 2 chloride pump. It specifically crosses the channel where potassium usually would enter. And then on the basolateral side, there is a sodium hydrogen ion exchanger where it then gets secreted into the interstitium of the kidney here, ammonium. I'm just going to show you that again. So glutamine, under the influence of glutaminase, converts glutamine into ammonium. The ammonium is secreted into the tubule, and it goes along, and at the thick ascending limb moves through the potassium component of the sodium potassium 2 chloride pump, and on the basolateral side is secreted into the interstitium of the kidney, the medulla specifically, by the sodium hydrogen ion exchanger. And here it splits up into hydrogen and ammonia. So here we have ammonia now. So this ammonium has now split up into a hydrogen ion and an ammonia molecule. On this side here, hydrogen ion, hydrogen ions are pumped into the collecting duct by hydrogen ATPase, and this then recombines to form ammonium in the collecting duct, and in that way we secrete ammonium in the urine. Now, in our case, our patient had hyperkalemia and an RTA, and this is frequently referred to as type 4 renal tubular acidosis, or its older name used to be, or is still, so-called hyporeninemic hypoaldosteronism. So in the face of hypoaldosteronism, the ENaC channel is no longer functioning properly, which means sodium isn't being absorbed, and therefore potassium is not being secreted because of the slower sodium reabsorption, as we've been through already. And because potassium is no longer being secreted and the patient develops hyperkalemia, the potassium concentration in the proximal tubule here is high, because higher potassium in the blood is being filtered into the proximal tubule, as one can see here. And this is thought to result in a higher potassium in exchange for hydrogen. And because of the higher potassium in exchange for hydrogen, the hydrogen ion concentration inside the cell, the proximal tubular cells, decreases, which results in an alkalosis developing inside proximal tubular cells. And this alkalosis inhibits the glutaminase enzyme, and therefore there's reduced conversion of glutamine into ammonium, and therefore reduced ammonium excretion. So this is thought to be the mechanism for the low ammonium excretion in patients with hyperkalemic RTA or type 4 RTA. But as I've mentioned, um, it's most likely a consequence of hyporeninemic hypoaldosteronism. So again, we end off with hypoaldosteronism or a state of hypoaldosteronism. So just to summarize again, we have a patient who has hyperkalemia with an inappropriate renal response. There is renal salt wasting as the patient is ECF volume contracted and therefore is not conserving sodium but wasting sodium in the urine. And lastly, the patient has a normal anion gap metabolic acidosis associated with hyperkalemia, which means the patient has a renal tubular acidosis or the so-called hyperkalemic RTA or type 4 RTA, which classically is also known as hyporeninemic hypoaldosteronism. So, in summary, regardless of where we started, whether it was with the hyperkalemia, the renal salt wasting, and the ECF volume contraction, or the metabolic acidosis, we end off with a state of hypoaldosteronism. And the final diagnosis in this patient was Addison's disease or adrenocortical insufficiency. And the patient was treated with fludrocortisone, which is synthetic aldosterone, which resulted in improvement in the acidosis as well as the hyperkalemia state. So that is the end of the first case. Mazhar, do you want me to move on to the second case now, or do you want us to take some questions at this point?
I think you can move on with the next case, and then we can take the questions towards the end.
Okay, fine. So the second case is a case that we saw a few months ago, a patient in our ICU. It was a patient who had hypokalemia and metabolic alkalosis, a 51-year-old woman who had a history of seizures and coma. She had a history of previous rhinoplasty, breast augmentation surgery, gastric banding, and bunion removal. There was a history of ingestion of 7 tablespoons of baking soda. And, blood pressure was 100 over 60 millimeters of mercury, and the ECF volume was thought to be contracted. So these are the blood results again and urine results of our patient. And I'm just going to interpret them one by one. Number one, the ECF volume contracted with a metabolic alkalosis and a low urine chloride concentration. This combination of volume contraction with a metabolic alkalosis and a very low urine chloride indicates either vomiting or remote diuretic use. In other words, the patient was using a diuretic, it was stopped a few days ago, and this is the consequence of the after the effect of the diuretic has worn off. Second, the patient had hypokalemia, as we can see here, 2,4, and the ratio of potassium to creatinine was 4,6. If we take 61 divided by 13,3, we will get to roughly 4,6, and this indicates renal potassium wasting. The appropriate renal response when hypokalemia is present, the ratio of potassium to creatinine, the urine potassium to creatinine, the ratio should be less than 1.5. So anything in excess of 1.5 really indicates renal potassium wasting, as can be seen in this case. And secondly, the patient had hypernatremia with a high urine osmolality. Hypernatremia of 161 with a high urine osmolality of close to 1,000. This indicated an appropriate renal response to the hypernatremia. In other words, when one is hypernatremic, i.e., dehydration, an appropriate renal response is to conserve as much water as possible and concentrate the urine as maximally as possible. Up to 1,200 milliosmoles per liter would be an appropriate renal response, and this is not bad at 958. Okay, so we had a patient, sorry, just to point out the acidosis, the pH was 7.5. Alkalosis, sorry, the pH was 7.5 and the bicarb concentration was close to 50 millimoles per liter. I just want you to also take note of the hemoglobin concentration and the hematocrit of 16 and 51%. I'll get back to that later. So what are the causes of the metabolic alkalosis in general? Firstly, you must interpret the alkalosis in the context of the ECF volume of the patient. So causes of metabolic alkalosis that are associated with a contracted effective arterial blood volume. We also then want to know what is the concentration of chloride in the urine. Is it low? Low is generally regarded as less than 25 millimoles per liter, or is it high? Higher than 25 millimoles per liter, because there are certain etiologies associated with a contracted ECF volume and a low or high urine chloride. The other is a metabolic alkalosis, but with an expanded effective arterial blood volume and usually hypertension as well. And this is, the causes here are really patients with mineralocorticoid or excess syndromes like Con syndrome, or mineralocorticoid-like excess syndromes. This would be things like apparent mineralocorticoid excess or 11-beta hydroxysteroid dehydrogenase deficiencies, or Cushing syndrome, or licorice ingestion. Then the other cause for an expanded effective arterial blood volume with hypertension is a large reduction in the GFR. So patients with acute kidney injury or patients with advanced chronic kidney disease who are given either oral or IV sodium bicarbonate administration. Okay, so regarding the causes with a contracted effective arterial blood volume and a low urine chloride, vomiting, nasogastric tube drainage. I always see this happening in our surgical ICUs. For some reason, the surgeons love to put the ICU patients with nasogastric tube drainage. Remote diuretic use, in other words, prior use of diuretics, and so-called post-hypercapnic state. So patients who have type 2 respiratory failure, who are in the ICU, who are ventilated, and they blow off lots of CO2, and they usually have an unmasking of a metabolic alkalosis, so-called post-hypercapnic states. These patients usually have a reduced effective arterial blood volume, and when you correct the ECF volume contraction, it corrects the metabolic alkalosis. The reason I've made all these causes in red, because these are, in my opinion, the most common causes for metabolic alkalosis associated with a contracted effective arterial blood volume. That said, by far the most common causes in practice, 90% I would say, is either vomiting or diuretic use. Those two, vomiting or diuretic use, will be probably 90% of the patients you'll see in clinical practice. On the side of patients who have a contractive volume, ECF volume, but with very high urine chloride, more than 25 millimoles per liter, the patient is still currently using a diuretic, Lasix, thiazides, and so forth. Really, things like diuretic-like syndromes, this would be, for example, Gitelman syndrome and Bartter syndrome. And then we have ligands that bind the calcium sensing receptor. Aminoglycosides would be common. Hypercalcemia is a common cause for this, which actually causes a diuresis, so-called nephrogenic DI. And then very rarely, cationic proteins. This would be light chains from in patients who have myeloma kidney. Very uncommon, very rare. I haven't seen a case yet. So again, on this side, with high urine chloride, the ones in red I would regard as the common etiologies for a contracted ECA volume, but with high chloride in the urine. So since the patient ingested a large quantity of sodium bicarbonate, remember she consumed 7 tablespoons of, sodium bicarbonate or baking soda, is the mechanism for her metabolic alkalosis bicarbonate gain. So to answer this, I just need to go back to the 1946. And this was a study performed in dogs. And what they did was they wanted to determine what is the normal renal response to a bicarbonate load. So they infused these dogs with sodium bicarbonate. They gave them IV sodium bicarbonate. And what they found was the following. The horizontal axis here indicates the plasma bicarbonate concentration, and the y-axis here represents bicarbonate reabsorbed by the kidneys. So what they found here was that there seemed to be a renal threshold for bicarbonate reabsorption at around 30 millimoles per liter. So the minute the bicarbonate concentration went above 30 moles per liter in these dog experiments, they found that uh, um, there was no longer renal reabsorption of bicarbonate, and the patients actually and the dogs actually had bicarbonate urea at a renal threshold of around 30, as can be seen here as well. The issue, however, is that they were infusing bicarbonate along with sodium. And hypovolemia is actually the trigger for sodium, for bicarbonate reabsorption. And as I mentioned earlier on in the other case, sodium content determines the ECF volume. So while they were infusing bicarbonate, they were also infusing sodium, which expanded the ECF compartment and switched off the renin-angiotensin-aldosterone system, in particular angiotensin 2, and the switching off of angiotensin 2, which is the stimulus for bicarb reabsorption by the kidneys, resulted in that being switched off and bicarbonate urea ensuing. So this was a study done in humans, and it's also a very old study. Prof. Davids actually just sent me this today. It was a study done in 1966 in humans. And here they didn't infuse sodium bicarbonate. What they did was they inserted nasogastric tubes um, in human subjects and drained as much gastric juice as possible during this period. And what they found was that with the removal of gastric juice and gastric secretions, even after when they got to 30 mol, when the serum bicarbonate got to around 30 moles per liter, the kidneys just continued to reabsorb filtered bicarbonate. And the reason for this is likely because of the ECF volume contraction induced by the hypovolemia due to nasogastric tube suctioning and fluid removal, which activated the renin-angiotensin system, resulting in angiotensin 2 being present, stimulating renal bicarbonate reabsorption. So it's got to do with volume status is really the key when it comes to metabolic alkalosis. If the patient is normovolemic, and angiotensin 2 is normal, there shouldn't be any bicarbonate when your bicarbonate concentration is in the normal range. However, if the patient is hypovolemic and angiotensin 2 is present, even in excess of 30 millimoles per liter, the kidneys will continue to reabsorb filtered bicarbonate. So it's got to do with volume status and hypovolemia and angiotensin 2 being present as the stimulus for bicarb reabsorption. So, what is the mechanism for the metabolic alkalosis during vomiting or nasogastric tube drainage? Well, there's two things that must be met for this to occur. Firstly, you must add bicarbonate to the body. And secondly, once you've added the bicarbonate to the body, you must maintain the metabolic alkalosis. So for point one, what is the normal fate of hydrochloric acid? This is a parietal cell with CO2 and water. And under the influence of carbonic anhydrase, it's converted into hydrogen and bicarbonate. The bicarbonate is reabsorbed in exchange for chloride, and the hydrogen, along with the chloride, is secreted into the stomach, and that's normally how we secrete hydrochloric acid in the stomach. And of course, you all will be familiar with the hydrogen potassium exchanger or the so-called proton pump. Now, when chloride exchanges for bicarbonate, we have gained a bicarbonate in blood. This will always be in an electroneutral fashion, as I mentioned earlier. Everything, all body fluid compartments are electroneutral. So when we absorb chloride for secretion into hydrochloric acid, it's in exchange for bicarbonate. And at this point, if we were to measure the pH, it would actually be as high as 7.5, and the bicarbonate concentrations will be as high as 30 millimoles per liter. We refer to this as an alkaline tide. So every day, this is a normal physiological phenomenon. Every day before you and I have a meal, and we're not using proton pump inhibitors, every day before we have a meal, in anticipation of food coming before lunchtime, our body starts producing hydrochloric acid. And at that point in time, before we start eating, we actually have a metabolic alkalosis because of this bicarbonate reabsorption. And this is referred to as an alkaline tide. Then what happens is after we start consuming food, the hydrochloric acid moves into the duodenum here. And in when food moves into the duodenum, it stimulates pancreatic juice production. And for those of you who can't remember, but pancreatic juice has an alkaline pH. So all that bicarbonate that we reabsorbed in anticipation to having lunch or supper, whatever the case may be, all that bicarbonate gets secreted along with the pancreatic juice, and pH now returns to normal. Bicarbonate in the serum returns back to normal. And the bicarbonate, along with the hydrochloric acid in the food we eat, is converted back into CO2 and water, and we're right back where we started. CO2 and water, CO2 and water. So this is what happens under normal physiological conditions. What happens with metabolic alkalosis during, what induces the metabolic alkalosis during vomiting or nasogastric tube drainage? Well, same thing happens up until this point. But of course, when a patient is vomiting or has a nasogastric tube in, the hydrochloric acid and gastric juice moves in the opposite direction, which means the bicarbonate remains in the blood because there's no pancreatic juice secretion. And this is actually how the metabolic alkalosis develops in patients who have vomiting or nasogastric tube suctioning. Now, after we induce the metabolic alkalosis must be maintained. So if this is the proximal tubule on this side, and I've got the cortical collecting duct of the nephron on the other side, the center here is the lumen of the nephron. As mentioned earlier, filtered bicarbonate, sodium bicarbonate, is reabsorbed by the proximal tubule. Number one. Number two, there are certain amino acids, sulfur-containing amino acids in the diet that gets secreted along with potassium in the urine. So we excrete during vomiting. Potassium loss is not in the vomitus, as so many people think, but hypokalemia that develops during vomiting is actually due to renal losses of potassium. Now, the reason we are losing potassium in the urine during vomiting is because under normal circumstances, this sulfate would be absorbed with a whole lot more sodium. But because when the patient is vomiting and becomes ECA volume contracted, angiotensin 2 gets upregulated, which results in sodium reabsorption, as I've mentioned earlier. Sodium reabsorption or sodium content determines ECF volume. So the ECF volume contraction due to vomiting stimulates angiotensin 2, which increases sodium absorption upstream in the nephron, the proximal tubule. But downstream in the cortical collecting duct, where potassium is regulated, because very little sodium is being delivered to this part of the nephron, because it's all being absorbed upstream. Potassium is excreted with the sulfate because the sulfate must be excreted with a cation. So it actually forces out potassium, and in a nutshell, we excrete potassium sulfate in the urine. And this happens in exchange for hydrogen. So potassium goes out in exchange for hydrogen. And of course, when the cell gains hydrogen, it lowers the pH inside cells, which further stimulates bicarbonate reabsorption. So these are the two things that maintains the metabolic alkalosis after it has been induced by the vomiting or the nasogastric tube suctioning. So the diagnostic workup for a patient who presents with a metabolic alkalosis is really to determine the urine chloride concentration. And a urine chloride concentration here, it says less than 10 millimoles. But in the context of ECA volume contraction and a low urine chloride, vomiting or recent or remote diuretic use would be the top two causes for a low urine chloride. And as I mentioned, these two would probably be the one of the 90% of cases of metabolic alkalosis you'll be confronted with in clinical medicine. If the patient has a high urine chloride and has ECA volume contraction, the patient is probably still using a diuretic, and one needs to identify which one it is. Is it the thiazide? Is it a loop, etc.? And as I mentioned earlier, in the context of ECA volume expansion with a high chloride, this points towards mineralocorticoid excess syndromes or mineralocorticoid excess-like disease, so CONS, etc. So are the kidneys responding appropriately to the hyponatremia? Remember, this patient had a sodium concentration in blood of 161 millimoles per liter. So are the kidneys responding appropriately? And I did mention to you earlier, with the urine osmolality of 958, the kidneys were responding appropriately because the urine was concentrated, almost maximally concentrated. But let me just explain why hypernatremia and hyponatremia has nothing to do with the sodium concentration. Dysnatremias, whether it is a low sodium or a high sodium, there's a problem with water. There's a problem with the movement of water in the body. That is really the problem. So here we have the ICF and the ECF, and we know this is 2/3. ICF is 2/3, while the ECF is 1/3. and the osmolality across is exactly the same. The osmoles inside, the reason the ICF has a higher volume is because it has twice as many osmoles. Now I'm going to show you what these osmoles are. Inside cells, it's things like DNA, RNA, ATP, proteins, enzymes. All these macromolecules inside cells are all negatively charged. And it's mainly because of phosphates molecules attached to all of these molecules. So the negative ions, if you want to think of it, inside cells are all these macromolecules, DNA, RNA, ATP, and proteins. The cation that counters all of these negatively charged molecules inside cells is potassium. So half of the osmoles inside cells is potassium, along with all these macro molecules, DNA, RNA, and so forth. Can we change the osmolality by exporting DNA and RNA out of cells? The answer is simply no. They are stuck inside. And would we like to change the osmolality by shifting potassium out of a cell or shifting potassium into a cell? The answer again is no, because if we were to shift potassium out of the cell, the patient would develop hyperkalemia and develop a cardiac arrhythmia and die. And of course, vice versa, if potassium were to shift into the cell, the patient would develop hypokalemia, and the patient would also develop a cardiac arrhythmia or muscle weakness. So the osmoles inside cells are stuck inside. You can't change the osmolality by exporting and importing the osmoles. Now, what is the main osmole of the ECF compartment? So just to remind everyone, the serum osmolality is calculated using the sodium concentration plus urea plus glucose. The reason we use these three molecules is because they are the insignificant quantities in serum. Yes, there's a little bit of magnesium and calcium, but the concentrations in blood is so low, it doesn't really contribute to the osmolality in a large way. The reason we say 2 times sodium is to counter, for all the negatively charged molecules or electrolytes that are associated with the sodium inside the serum, and that's mainly chloride. So instead of saying sodium plus chloride plus bicarbonate, we just simply say 2 times sodium to counter for all the negatively charged molecules attached to the sodium. As I mentioned again, as I've been mentioning, body fluid compartments are neutrally charged. So for every positive, there must be a negative. So we say 2 times sodium plus urea plus glucose. So a normal sodium is around 140, and therefore the main osmole inside the ECF compartment is sodium. So can sodium shift into cells? Can we change the osmolality of the ECF compartment by shifting sodium into cells? The answer is yes, sodium can shift into cells, but the inside of cells, they don't like high sodium concentrations. So the minute sodium moves into a cell, it activates the sodium potassium ATPase pump, and the sodium gets pumped out almost immediately back into the ECF. So, in other words, for all practical purposes, you can't really change the ECF osmolality by shifting sodium into a cell, because it actually just gets pushed out again by the sodium potassium ATPase pump. So since the osmoles are stuck in their respective compartments, sodium is stuck in the ECF, potassium is stuck inside cells, and all these other molecules, the only way to change the osmolality is by shifting water across membranes. This is really the key is that In the face of changes in osmolality, in the ECF, water has to move in order for osmolality to be equal across both sides of the membrane. I must just mention here that an osmolality force is a very powerful force. And a 1 milliosmol difference across a cell membrane is the equivalent of nearly 20 millimeters of mercury. And when that happens, water moves across membranes within split seconds to ensure that osmolality across a membrane is the same. So an osmolality force is a very powerful force for the movement of water across cell membranes. So let me just show you, our patient here has a sodium concentration of 160 millimoles per liter, and the osmolality has now gone up in the ECF to 330 milliosmoles per liter. That means there is an osmolality difference across the membrane of 30 milliosmoles per liter. Remember, I said a 1 milliosmol difference is the equivalent of nearly 20 millimeters of mercury. So we could say that the pressure difference across this membrane is 600 millimeters of mercury. Very, very high. I don't think anybody would want to have a blood pressure that high. So an osmolality difference of 30 is a very powerful force for water to move from the ICF into the ECF. And when water moves out of the ICF into the ECF, the ICF compartment shrinks. Sorry. And at this point, when the ICF loses volume, we refer to this as dehydration. So I just want to make the point here that you can only really say a patient is dehydrated clinically if you know that the patient's sodium concentration is high. All the other features that we look for on clinical examination for dehydration in inverted commas is actually ECF volume contraction. So when you are on ward rounds or you're seeing patients, you should actually say the patient is either hypovolemic or ECF volume contracted. Only once you know what the sodium concentration is. If the patient has hypernatremia, then you can say cells are shrunken and the patient is therefore dehydrated. So water will move, as I've shown you here. So water moves into the ECF compartment, and it will move until the osmolality across the membrane is the same again, and then it stops moving. So, as I've mentioned, dysnatremias are a water problem. Whether it is hypernatremia or hyponatremia, water has moved. In the case of hypernatremia, water has moved out of cells. In the case of hyponatremia, water has moved into cells. In other words, cells are swollen in hyponatremia. So what are the mechanisms for water control in the body? Number one, in the hypothalamus, we have the osmostat that monitors changes in serum osmolality. And when there are changes, the hypothalamus then sends a signal to the thirst center, and it either stimulates thirst, so you drink water in the case of hypernatremia, and if there's hyponatremia, it will switch off the thirst center, and the patient or the person will avoid drinking water. On the other hand, it also sends signals to the posterior pituitary gland to secrete vasopressin or ADH. And in the case of hypernatremia, ADH will be stimulated, which will result in renal water retention or maximally concentrating the urine. And in the case of hyponatremia, ADH will be switched off and the patient will excrete dilute urine. So an appropriate renal response in the face of hypernatremia would be concentrated urine. And an appropriate renal response in the face of hyponatremia, a low sodium, is to excrete dilute urine with an osmolality of close to 50. So why was the patient hyponatremic in our case? Well, there's only two ways to develop hypernatremia. It's either due to sodium gain or water loss. And as I've mentioned, when sodium content has increased, water content has increased. So if the hyponatremia was due to a gain of sodium, the patient would have been edematous. Now, we typically see this more in an ICU setting, where the patient usually receives lots of isotonic and hypotonic fluids, and these fluids results in sodium gain along with fluid overload, ECF volume expansion, edema, etc. Typically seen in hospitalized patients in the ICU. The other mechanism for hyponatremia is then water loss. And the patient, when you see them on admission, will be clinically ECF volume contracted. So in our case, we thought that the patient was likely ECF volume contracted, and therefore the hyponatremia may have been due to volume loss and ECF volume water loss. So just to come back to the case, so we've got a patient who had ECF volume contraction with a metabolic alkalosis with a low urine sodium. We were considering these two here: remote diuretic use or vomiting. She also had the hypokalemia with renal potassium wasting. And she had hyponatremia, and she was ECF hypovolemic, which we thought was due to water loss. As I said there, a water deficit other than due to diabetes insipidus. So all in all, we decided that the most likely cause of this patient's severe metabolic alkalosis wasn't the baking soda that she consumed, but she likely had vomiting prior to presentation. And with her history of breast augmentation, as well as gastric banding and rhinoplasty, etc., we actually ended up referring the patient to psychiatry because we thought the likely diagnosis was body dysmorphic disorder. So she actually ended up having that as the final diagnosis, and the vomiting was probably as a result of purging in an attempt for weight loss. Just one other thing. In our patient, I said earlier, the patient also had a very high HP and a very high hematocrit. And this also pointed towards hemoconcentration and ECF volume contraction. So in fact, the patient didn't only have metabolic alkalosis due to vomiting, but also had a so-called contraction alkalosis due to the ECF volume contraction. Thank you.
Thank you very much, Prof. This was an absolute masterclass in electrolytes. Even though you said two cases, you have covered both sodium, potassium, and water issues. So it was a great presentation. Thank you very much. I myself personally got a nice refresher, and the part where the bicarbonate, is reabsorbed with the ECF contraction, that concept kind of made sense to me today. So thanks for that. Really appreciate. As you say, there's never a day that you don't learn. Every day there's something new that you learn. So for me, this was something that I've learned today. So we'll go with the questions. We actually have quite a bit of people online, about 130 plus. So please feel free to raise your hand and speak if you would like to. Otherwise, please drop your questions on the Q&A. quite a few people have also asked me about the recording. So it will be posted on YouTube. Once it's available, I'll just share it with you. So please feel free to post questions. Uh, Prof, we have got two questions in the Q&A. I
Sure.
will read them for you. I believe the first question you probably already answered during the talk, but maybe just as a review. So it says in the second slide, so the first case, in the second
Yeah.
slide, how did we arrive to a potassium creatinine ratio of 3.7? So I believe that's the calculation.
So maybe I'll just show can I just share that again, Mazhar?
Yes, 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 sure.
Um,
Letitia, can you allow Prof to share the screen again?
Yes, you can go ahead.
yeah. Thanks, Letitia. Um,
Seems to be a
I'll,
bit.
I'll open it here. It doesn't seem to want to work now, Mazhar.
Okay.
Let me just okay. Okay. There. Can you see it now?
Yeah, I can see it now.
Excellent. Okay, I'm just going to go to the start again. So the second slide, this
Yeah.
one.
Yes, yes.
How did we arrive to this potassium of 3.7?
Correct. Yeah.
Okay, thank you for the question. So in the urine, we sent away a spot sample of urine, and the numbers in the urine indicated that the amount of potassium in the urine was 37 millimoles per liter. And because creatinine is measured in micromoles per liter, we have to convert micromoles, 10,000 micromoles per liter, into millimoles per liter, which is really divide by 1,000, which means if we work out the ratio, it's going to be 37 divided by 10 millimoles to convert it into millimoles. Convert micromoles into millimoles is 10 millimoles. And that would give you exactly 3.7.
Thank you,
That's
Prof.
it.
Yeah, thank you, Prof. I believe the answer is now clear. So the units are a difference. So please take into account whenever you're doing these electrolytes, just make sure that the units are appropriate to get the correct ratio. The second question by Victor is asking if there is an easy way to say ECF volume contracted.
Yes, hypovolemia.
Yeah.
So I prefer ECF volume contraction because it tells the individual exactly which compartment the issue is in.
Yeah.
It makes you focus on the ECF. Whereas hypovolemia, a lot of people wouldn't immediately think of the extracellular fluid compartment. So generally, I prefer ECF volume contraction because it puts the focus in your mind that there is the ECF compartment is contracted and that the fluid that you need to administer is to specifically expand the ECF compartment. So this is why you'd use something like isotonic saline or Ringer's lactate because the isotonic fluid, which has the same osmolality as blood, will then remain in the ECF compartment. None of it will actually move into the ICF because it does, if you remember that slide that I showed of the 1 liter, maybe I'll just show it again, Mazhar.
Yeah.
Um, okay, I don't know. Anyway, as I showed earlier, when I showed that that slide of the sodium content determines the ECF volume. When I doubled the ECF volume by adding a solution with the same concentration as the solution that it was going into.
Yeah.
the ECF that compartment doubled in size
Mm.
by adding
Mm.
more sodium molecules to that compartment, but
Yeah.
without changing the
The
concentration.
concentration. Yeah.
So when we say a solution is isotonic, we actually mean it's isotonic to serum osmolality.
Mm. Mm. Mm.
And that's why we use isotonic solutions in
Mm.
patients who are in hypovolemic shock.
Yeah.
So we can expand the ECF compartment.
Mm. Mm. Thank you, Prof. Um, the other question is again regarding the first case. Why is an anion gap of 17 normal?
Good question. So a normal, it depends on how you calculate the anion gap.
Mm.
So if you remember, it's sodium minus chloride plus bicarbonate. However, if the patient's potassium concentration is high, then you should include the potassium concentration in the equation. So in
Mm.
this case, with the patient at hyperkalemia,
Yeah.
it's sodium plus potassium in brackets
Mm.
minus bicarbonate plus chloride in brackets. Now,
Mm.
a normal potassium concentration is 4 millimoles per liter. And if we exclude the potassium from the equation, then the normal anion gap, the index value should be 12 millimoles per liter. But the
Mm.
minute I add the potassium, which is 4, it will then the normal is now 16 millimoles per liter, plus minus 2 millimoles on either side.
Mm.
So in other words, up to 18 millimoles, if you include the potassium concentration in the calculation, would be normal.
Mm.
Hence, 17.5 is still regarded as normal in this case, because in the calculation, I included the potassium concentration in the calculation.
Thank you, Prof. Um, Another question is what is urinary anion gap and its value?
So the urinary anion gap really, or some people talk about the urine net charge.
Mm.
So I don't like to use that on its own to determine ammonium excretion. It's in the urine net charge or the urine anion gap is in an attempt to identify whether there is ammonium in the urine. Sorry, I think I should share my slide, Mazhar, so I can explain this better. You know, a
Yeah,
picture is worth more than 1,000 words. Let me just
absolutely.
again attempt to share my slides here.
Okay. I can see the first slide. I'm not sure if
I
it
can't
is
see it here on my. I can't seem to
okay.
see it here. Oh, they didn't disappear. Let me just.
Um,
Oh, there it is.
yeah, yes,
Can you
I
see it
can see it
now?
now. Yes, yes, yes.
Okay.
Yeah. So
So I'm
yes.
just going to go down to that. Here we go. Okay. So a lot of textbooks, if we look at this as the urine, they will say you must add the sodium plus the potassium minus the chloride, which is the urine anion gap or the urine net charge. And
Mm.
if the urine net charge is negative,
Yeah.
it would indicate that there is ammonium in the urine.
Mm.
In other words, if I only used sodium, potassium, and the chloride, if I looked at it here, without looking at the ammonium concentration, if I only use these three
Mm.
as the urine anion gap is, some people recommend, then yes, you would be able to say from here that the urine net charge is positive, which
Yeah.
means there's no ammonium in the urine,
Mm.
and your interpretation would be correct.
Mm.
However, sometimes the urine chloride, as you can see here, is it does look like there's a urine net charge and is positive, and there is no ammonium in the urine. However, you can see that here, this brown block here, there are other anions that we haven't actually identified.
Yeah.
Remember, all of these must add up to 163. So 120 millimoles is only accounted for of this 163 is chloride. But there's another 40 millimoles of a yet unidentified anion. And sometimes that anion may be excreted in large quantities. And then you would actually pick up that there is actually lots of ammonium in the urine. So if you only look at sodium, potassium, and chloride, you will be correct some of the times, but there are going to be times when there is an unusual anion excreted in large quantities, and then you would incorrectly interpret it as saying the urine net charge is positive and there's no ammonium, when in fact there is lots of ammonium in the urine. That's really so I don't like using the urine net charge on its own. I prefer people do it like this.
Yeah.
Collect all the numbers that you need and put it into this chart, and then it stands out. You immediately see that there's lots of anion, but in this case, the the ammonium excretion was still quite low despite that added amount of anion that we haven't identified yet.
Yeah.
Does that answer the question?
Yeah, it does. It does. It does, and it's probably pulling the potassium out as well. Those
Correct.
negative that were not accounted for.
Yeah.
Yeah. Thanks, Prof. The other question is, thank you for the nice presentation, Prof. My question is about anion gap in the first case. It was 17.5 and it was stated as NAGMA. I think we've already answered this, so
Yes.
we won't go with that. The next question was, what is the cutoff point for high anion gap metabolic acidosis? In this case, anion gap was 17. Again, I think it's more or less the same question.
Yes.
The next question, may I
Sorry,
request?
Mazza, maybe I just want to say here, if the anion gap was, say, 20, so it's more than that value that I've indicated.
Yeah.
In its strictest terms, yes, the anion gap is increased. But it tells me that whatever the anion is, it's not there in significant quantities. If the patient has a very severe metabolic acidosis and it's a high anion gap, but the anion gap is 20, it's not high enough to explain the severity of the acidosis. Okay, I think I must, maybe I didn't say it in the talk, but the anion gap tells you two things. If the anion gap is increased, it means that the mechanism for how the acidosis developed is due to an acid gain. Lactic acidosis, ketoacidosis, toxic alcohol poisonings, and so forth. If the anion gap remains normal, in other words, it hasn't increased, it tells you that there's bicarb loss from the body. So a normal anion gap indicates bicarb loss. And the bicarb loss is either gastrointestinal or genitourinary if there are fistulae between the gastrointestinal tract and the genitourinary tract, or renal losses of bicarbonate. That's really it. Really, for all practical purposes, really gastro loss of bicarb or renal losses. And by asking yourself, are the kidneys responding appropriately by excreting large amounts of ammonium? If you don't find that, if you find very little ammonium in the urine, then the kidney is in fact the cause for the bicarb loss. And as I said, you can immediately diagnose renal tubular acidosis.
Thank you, Prof. All right. The next question is about the slides in the talk. I said, we will once it's ready, we will share it on the main Afghan group, and it will also be posted on the Afrin YouTube channel, so you can access it once it's ready. I believe this is going to be the last question, Prof.
Yeah.
Something about TTKG in assessment of hypokalemia.
Yes, no, good. So just to let you know, TTKG is no longer used in nephrology. It should actually be removed from textbooks. I don't teach it anymore. And the reason for that is because the inventor of TTKG, Professor Mitch Halperin, he actually realized that the TTKG is not accurate. Because the TTKG looks at the potassium concentration or the gradient for potassium secretion in the cortical collecting duct only. But what they've realized further down in the collecting duct, in the medullary collecting duct and so forth, they actually identified other potassium channels that also cause further potassium secretion. They call them PK channels or maxi K channels, in fact.
Right.
So I recommend not using the TTKG as a marker of whether the kidneys are responding appropriately or not. Simply use the urine potassium to creatinine ratio. So there's a saying now after Mitch Halperin decided not to use the TTKG anymore. They say invented by Halperin and killed by Halperin.
Right. Thank you, Prof. I see no further questions. So I would like to thank you again for this insightful, comprehensive talk. I believe it was a great talk for everyone. Everybody thoroughly enjoyed, and everybody's asking for the slides for the revision. I've also got some fellows from South Africa asking if this is going to be posted on YouTube, because everything that you've been talking and teaching them is all in this one talk. So I will make sure that I do share it with them. And it is
Mazir,
always
they should have already heard this and know it.
Absolutely, absolutely. I think by the time they write their final exams, they will know all of this from their side. So yeah, thank you so much, Prof. It has been a pleasure, and it's always nice to get a refresh from you on electrolytes. If there is an additional slot later in this year, I will again reach out on you. Maybe you can give us a talk on hyperkalemia and the novel treatment that you had presented. I think this is something that is not very clear, especially from the Tanzanian side at least. So I try as my best to try and teach the right way of doing the potassium shift. So maybe that's something that we can do it on another day when you have some
Sure.
time. Right. Thank you so much, Prof. It was nice having you, and I wish you a good evening. And you're more than welcome again next time.
Thank you, Mazir. It was my pleasure.
Thank you very much.
Okay.
And thank you,
Bye-bye.
everyone. Have a nice evening. Thank you, Letitia.
Thanks, Letitia.
Thank you, everyone, and have a good evening.